we live? Hello.
Hi.
Welcome to Doc Talk Live. I'm your host, Dr. Brad Goodman. I'm with Dr. Clara Chung today. One of the first days where people can actually be out in public, right?
Yes.
With face masks and things like
Our
that.
governor lifted some orders, so some people are out.
So I'll give you a little handshake.
Yes.
This is the new way. Maybe a little foot here. But anyway, Dr. Chung specializes in allergy.
Yes.
And I appreciate you doing this today.
Sure.
You know, I was just going through your office, and it's amazing how many topics we could hit on: eczema, asthma. But it seems like the whole country is, in a way, becoming an immunologist and a virologist.
Yes.
So I guess I'd like you to start a little bit with COVID and teach us a little bit, if you could, about immunology. Is that a tall order?
Yeah, okay.
Make it, try to dumb it down for us.
Yeah.
But a lot of this information, I don't think I learned in medical school. I don't think we knew about this stuff that well in medical school.
Yeah.
So teach us about immunology and how that applies to allergy.
So I think one of the main problems about COVID right now is that none of us know everything about it. And every day we're learning something new, and I think that's actually one of the big problems with why we couldn't tamp down the curve. Because in the beginning, all we heard was cough, fever, chest tightness, and if you didn't have that, and then certainly you didn't have it, and you had to have visited China, and you had to have come off of a cruise, or
Right. In fact, I thought of it as a rich person's disease. I mean, poor people aren't going on cruises around the world.
Right. Initially, those were the people who were seeing, right? They were the people who had money. But now, clearly, that's not the case, and we're seeing that once again, there's a disparity in wealth and healthcare, and it is hitting or underprivileged population more because they tend to have more what we call comorbid conditions. So they tend to have baseline more diabetes and hypertension, obesity, and things like that, which then puts them more at risk for having problems with COVID, a dire consequence of having COVID.
COVID, though, I guess people who get sick with COVID, correct me if I'm wrong, are kind of like people who have allergies in a way. They have an overactive immune system. So there's people that get COVID and are totally asymptomatic.
Right.
And they develop antibodies to destroy the virus and have no symptoms. And then there's, all the way on the other end of the spectrum, there's people who develop antibodies, but actually it's such a fulminant response that it actually causes real problems.
Right. And so we don't really know who those people are. I mean, we know that the ones that are that have other underlying health conditions are more likely to have it, and the people who are older are likely to have it, and that's what we kept hearing. But now we're seeing the younger people, and so we don't know who those people are going to be. But like
I'm here with my fiance's son, and he has an allergy to nuts. Well, I can eat nuts. I don't have problems eating nuts. So what does that mean? What's his immune system doing as opposed to mine?
So when, in your case, if you have a problem to nuts or an allergy to whatever, to pollen, to dust mites, to animals, whatever, if you have, most people can inhale it and be fine. But the people who are allergic to it basically make antibodies against it and view it as foreign. And when it views it as foreign, it releases a bunch of different chemicals. And when the cells break open and these chemicals release, there are things like histamine, there's things are known as cytokines, things that are released that then cause symptoms. So in the case of allergy, when histamine's released, it causes symptoms of sneezing and itching and stuffiness and whatever. And so we take an antihistamine to block the effects of histamine. And so with allergies, if we know it's allergy, there are some medications we know that we can give ahead of time to basically stabilize these cells so they're less likely to break open and less likely to have that allergic response. There's also stuff like immunotherapy, like allergy shots, where you can actually go on allergy shots to teach your body not to be allergic to it. And
why do you call it immunotherapy?
So, what happens? Okay, let's go more basic.
Okay.
Okay, so our body makes things called immunoglobulins that are proteins that help fight infection.
Right.
And so the primary ones that are made are IgG.
I'm so sorry.
IgG, IgA, IgM, IgE. And within IgG, there's like 4 different subclasses. Of all of them, IgG, A, M, E, the ones, we have the greatest abundance in IgG. And I like to view it like as the military. IgG is the army. We have the most amount of troops within the army, IgG.
So they're very non-specific.
Right.
Is that
yeah,
it?
But even within that, there's like 4 different branches of IgG. So it could be special ops, it could be infantry. I mean, there's subsets within the army.
Okay.
That's IgG.
Okay.
We also have IgA, IgM, and IgE. IgA and M tend to be more specifically mucosal things. So, mucous membranes line your respiratory system, but also your gut.
Uh-huh.
We also have IgE. We think originally we have IgE to fight off parasitic infections. But in this day and age, we don't really have parasites so much in this type of setting. And so IgE became a marker of allergy. And so
IgE is the marker. Okay.
of allergy. And so IgG's the primary one that fights infection kind
Okay.
of in general. When we have something that we're allergic to, we have IgE that's in our body, and the IgE learns to become specific to something in particular, like peanut.
Peanuts.
Or nut.
Okay. All right.
And when you ingest the peanut or nut, whatever it might be, there are what we call antigens. So those are the proteins that come off of whatever the offending agent was. And we make IgE, or people who are allergic, make IgE that's specific to that antigen. So they make IgE that's specific to what they're allergic to. But you, who don't have any allergy, you have IgE running around, but it's not really specific for anything, and so nothing really happens. But when you have IgE, you kind of view it as a docking station almost. Like IgE is like this, and they have receptors, and then the antigen comes and docks on it. Once it docks on it, then it sends signals to break open the cells, and once the cells break open, then all sorts of bad stuff happens.
Let me get you back. Why is it called immunotherapy? What are you doing when you give a kid immunotherapy?
So if you're giving allergy shots to someone, well, so you can't really give allergy shots for food, but let's say allergy shots for dust mite and pollen and animals and stuff.
Okay.
Eventually, with allergy shots, you can build up IgG specific to that thing, that tree pollen or the dog or whatever. And then the IgG comes and blocks the IgE receptor. So now when you come in contact with what you're allergic to, the antigen can't get onto the docking station, because basically IgG that you've created to that is now blocking
Okay.
that.
So
you're
you build
modulating
up the IG Goodman,
Yes.
and that is blocking the IgE, the IG Edward.
Yes.
Okay.
Not to disparage anyone named Edward, but it's immunotherapy because you're changing your immune system. You're teaching your body not to be allergic to what it is, and so it's almost like a vaccination.
Okay, but that's for dust mites, pollen, but that doesn't work for food. You said.
Right. So right now, there's not a shot for food. There are some protocols to do oral desensitization to some foods.
Okay.
Yeah, there aren't shots.
All right, I'm going to run through these questions and see where this takes us. So if I test positive for cashews specifically, should I avoid all nuts or all tree nuts, or how does that work?
Yeah. So there are people who are positive to just cashew and not the other tree nuts. And if you really are only allergic to cashew, then theoretically you could eat the rest of them.
How would you know without eating the rest of them?
Well, you have to get tested.
Uh-huh.
And so you can get skin testing or you can get blood testing, and then within the blood testing there's actually some more sophisticated tests that they've developed more recently where they can identify which protein component within a particular nut or peanut or whatever that you're allergic to, and then tell you whether you're more likely to just have the kind of allergy where maybe your mouth itches and you might get rashy, or you might actually anaphylax and have the risk of dying. And
so you're saying the tests have even gotten better though?
Yes.
So
yes,
like he was tested when he was 3, and that's 12 years ago.
Yes.
So he should be retested.
It's worth retesting. But then it's also worth knowing like their food family groups. So even though you're allergic to cashew is actually related to mangoes and pistachios. And do you ever eat mangoes or pistachios?
Mango's a fruit, right?
Yeah, I eat mangoes. I don't eat pistachios though. I stay away from them.
Yeah, so some people who eat mangoes, it's in the same family, so that they'll kind of have a problem with that. Okay, so
the
back
fruit mango.
Yeah.
Okay.
So back to your question of like if you're allergic to cashew, should you eat other tree nuts? If you're allergic to one tree nut, you're really probably going to be more likely to be allergic to other tree nuts, and so kind of the general. If you haven't bothered to get tested, it's really just like don't do it. But if you know specifically, then you don't necessarily have to avoid each one. But I'll tell you, kind of the way we counsel people is, internally within the family, we know that that you can eat pecans and almonds and be fine, but you can't eat pistachios and cashews. So when you go out to the general public and you go to school, you are tree nut allergic. It's too much responsibility to give to your friend's mom to decide whether this nut was okay or not. Like you just go through life saying I'm allergic to tree nuts, but kind of internally within the house, hey, I can eat this.
So that brought me to my next question. What if I tried pecan and did not react the first time? Does that mean I'm not allergic? Or does it mean if I try it again, I might be really allergic?
Yeah, you could be. So no one's ever allergic to something on the very first time they eat it. Your body has to see it once to realize it doesn't like it. So it's usually not on the first time. It's usually on the second or third, or it could
so
be
once
the 20th.
again, it gets back to testing. You really should test.
Right.
So because who wants to test it that way by
Right.
having an allergic reaction, which in the worst case scenario would be an anaphylactic reaction, right?
Which could be done. And then sometimes there's kind of borderline. So, the tests aren't foolproof. Sometimes it'll be kind of borderline, and if it is, then we'll have someone come into the office with that food and eat it.
Okay.
In small increments.
So do you have equipment for resuscitation and stuff like that in the office?
Yeah, but there's always 911 too. But
Yeah, I mean, that's a scary thing
right,
in
right.
an
So-
office setting.
Right. So yeah. Okay.
Okay, so is it genetic? Say his father has a nut allergy. Is it genetic?
So the tendency to be allergic is genetic, but not to be allergic to the same thing that your parents are. So if you're and we talk about it in terms of like allergic disease as a whole. It could be asthma, it could be nasal eye allergy, as a hay fever kind of thing. It could be a food allergy. It could be eczema. So it's just kind of the allergic tendency, which we call atopic, atopy. So if one of your parents has some atopic problem, you have like a 50% chance of getting a problem. But if both your parents have some allergic issue, then you have like a 75% chance of getting something.
So just because his dad can eat pine nuts wouldn't mean that he could eat pine nuts, in other words.
Correct. It has no bearing.
Mm-hmm.
And it might not even be, I mean, it could be food allergy, but it might not even be in the nut family. It might just be, it might be egg for you.
Yeah.
Or it may be something totally different. I mean, it's just like you're allergic to dust mites.
Can allergies develop in utero?
Probably not, but we do think, but clearly some of these babies get sensitized on breast milk. And certainly breast milk is the best thing a mom can do for a baby if they're able to breastfeed. But what
But
the
if
mother
if a mother ingests nuts while she's pregnant, is that going to trigger?
It can. It doesn't usually,
Okay.
but it can. So sometimes, we see, babies as young as 4 months old, and our oldest patient's like 93. And so we see a wide variety of people in the clinic. And so sometimes we'll get a little baby who's, 6 months old and they 4 months old, and they have eczema. That's just insane. And it's just like, why is this baby having eczema already? And
I think I took the eczema brochure, yeah.
And at that age, it's really probably not something environmental. It's probably, it's definitely not pollen. It's possible it could be dust mite or the dog or whatever. But often it's a food. But at 4 months of age, like that baby still hasn't even really tried solid foods yet. So so then it's like tracing back, okay, mom, what do you eat? And getting a food history from mom.
But
And then
eczema is
testing
like
the
a
baby.
skin issue
It is.
as opposed to a food allergy.
But it's a skin issue triggered by a food allergy.
Triggered by a food, okay.
Yeah, right. So when the baby's drinking breast milk and mom is eating tree nuts a lot, then the baby will sometimes get
But that's not in utero, that's after the
Yeah.
baby's been born.
Yeah.
Okay.
Yeah.
What about just how, have you been open during this? We have.
Yeah.
So how do you, and are people coming in like, is this COVID or is this allergy?
Yeah.
Are you seeing that?
Yeah.
And can you actually distinguish those clinically without a test?
Okay. Well, first of all, we do test here.
Sure.
Okay. But yes. So back to originally the COVID, it was cough, fever, chest tightness, and if you had anything else, it clearly wasn't COVID. But that's not true. And so even in the beginning, there were like, these little like poster things that you could put up, and it was just like, we're not putting that up because I don't think that's right. Because now we know that the COVID patients have all sorts of other stuff too, and that's when it's like, oh, now we really are having overlap with the symptoms of allergy, and it really is getting more confusing. So, cough you can get with both.
Right.
Chest tightness, if you just have straight up allergy, probably you don't get the chest tightness, but a lot of people with allergy have asthma. So if you have asthma and you have allergies, then the cough and chest tightness could be COVID, it could be your asthma.
And a lot of people are stressed out.
Right, and then there's anxiety on top of this, and then if you have the tendency to have reflux, your reflux can act up when you're, partly because you're anxious, but partly because everyone's sitting at home and you have easy access to the refrigerator, and so people are putting on some weight, and then that may aggravate their reflux. But also now that they're working from home and going and doing school from home, they've actually got more free time to actually be outside, and so now their pollen, it's like, oh yeah, the spring is actually even worse than normal because I'm not spending as much time indoors, I actually have time to go outside. So, sneezing, usually you don't see in COVID.
Oh, that's good to know.
You have an allergy. But
that's how we spread it in COVID.
Right. But congestion, you can see both. A little sore throat, you can see in both. Fatigue, you can see in both. Now, COVID, like the people who like really have it badly, I mean, they're super fatigued. Like they can't get out of bed fatigue.
Sure, they're like flu fatigue.
Right, but, there's all these people who are walking around with either totally asymptomatic or just really mild symptoms. And so, you know, the ones who are like can't get out of bed, that is kind of like, oh, well, that really probably is COVID. But if they've just got some mild fatigue, like, I don't know, you could still have COVID. So the fatigue with allergy is, I'm really draggy. I don't feel great. It's like I'm walking around with a perpetual cold, but I can get out of bed. I can go to, you know, do my schooling and stuff like that. Okay, but
now let me pause for a second. Talk to your daughter. So Emily, is there any questions there? Or are we good? Sometimes people will type in questions.
Well, there was a question earlier about have allergy shots improved? I think that means
just
in general, and then you guys addressed it, I think.
Allergy shots, have they improved?
They have improved through the years, but improved in terms of their efficacy, but maybe not improved in terms of convenience. So for the longest time, and there are still some people who allow this, they allow people to get their allergy shots from home. And a board certified allergist doesn't allow that because our extracts are much stronger, and so we get better results. So we don't do the on shots, give yourself shots at home indefinitely. We do it in the office. There are a bunch of rules because we're pushing the doses higher, stronger, but we get better results. And so there's a finite period of time. Like we're going to do this.
And again, this is for like dust mites and pollen. It's not for
mold,
food.
Not for foods, but for dogs, cats, dust mite, all the different kinds of pollen, grass, trees, weeds, mold.
Okay. Anything else there, Emily? So I'll give you. Emily knows my daughter, Annalisa, and she has turned me on to this anime show called Cells at Work. Have you ever seen that, Emily?
I have not.
It's unbelievable. It's an anime show. It's all about how the body works, and it's really geared toward the red blood cells and the white blood cells and immunology.
Yeah.
So, and it's an animated Japanese thing.
Yeah.
It's just fascinating, and they have the immunoglobulins and the neutrophils and the macrophages, and it's just I've learned more watching that cartoon about your particular subject than I did in medical school, hands down, no doubt. How did you decide I want to do this? I want to go into allergy. Tell me your path. How did you get here?
Okay. So
Is that fair?
Yeah. No. So I really like kids. So it was like, okay, I'm going to go pediatrics. So I don't know if you know this, if you remember this, but we met 1,000 years ago at Emory.
Yes.
I did my internship there. I think you were doing a transitional year, maybe.
Right. Yes.
And so I did my pediatrics thing, and then I ended up coming to UAB, to Children's Hospital.
So this would have been 1990 to 1991?
Correct.
Okay.
Correct. And so I knew, okay, I like kids, I'm going to do pediatrics. But as time moved on, it was like, yeah, I don't really think I want to do general pediatrics. What I think I'm going to do a subspecialty. What can I do where it's easier to be at home and be a mom and that kind of stuff.
So did we
But-
interface at Eggleston?
We did.
Yeah.
You didn't have to go to Grady, did you?
Oh, all the time.
Oh, yeah,
But
sure.
when I did pediatrics, I did it at
At
Eggleston.
yeah.
Actually, I had to do. I'll tell this story because I think it's fascinating. But I did have to do a rotation at Grady. The transitional ones, they made me do the neonatal ICU, and it was a hard thing because you were on call every other night.
Right.
And it scared me because if I got called in the middle of the night and I had to intubate a preemie, that was scary to me.
Yeah.
And they had me practice on cats, and I'm like, I'm not ready. I cannot do this.
Yeah.
And I would be in my call room, just sitting, literally afraid they were going to call me.
Yeah.
It was very scary, but they never called me, thank God. But yeah, I enjoyed being at Eggleston. That was a lot of fun for me.
Yeah.
And there were some very bright people. There was one guy, I can't remember his name right now, but he actually came to Birmingham for a while, went to UAB, but I can't remember. He was very bright.
Judd,
that's it.
Yeah.
Yes.
Yeah, so I think Judd's back on, I think he's on staff at Emory at Eggleston.
Really?
So, yeah.
He was really good. We go to
Yeah.
codes together and
Yeah,
knew
yeah.
exactly what
Yeah,
to do.
yeah,
And I
yeah.
was like,
Yeah,
well,
yeah.
again, that happened. Any more questions there, Emily?
Yeah, so we have some questions in terms of maybe talk about seasonal allergies being affected by the region you're in. So that's part one, and then part two is are seasonal allergies affected at all by COVID, or it's
Okay.
yeah.
So seasonal allergies imply season, right? So spring season is tree pollen, summer is grass, fall are weeds, mold, which can be year round because they're indoor molds, tend to be worse in the fall because there are more outdoor molds in the fall. When the leaves fall and they've gotten kind of rainy and you pick up a leaf and there's like dots on them, that's mold. So whenever anyone's like kicking the leaves or anything, like mold spores are spewing. So that's kind of the general rule of seasonal allergies. But depending on where you live, what actually grows there is a little different, and the length of your seasons are different. So this is Birmingham, Alabama, and something's always blooming unless it gets super cold, and we're only super cold for maybe 6 weeks out of the year. So our tree season will really start in January, as opposed to in the Northeast where tree season's really probably not going to start till more like March. There are, like in Texas, like there's this thing called red cedar, and that it's like terrible, but we don't get it here. That it doesn't grow here. Back when I was a kid, I guess you were a kid too, but even older, like you would hear about like, oh, the neighbor, they moved to Arizona because their kids' allergies and asthma were so bad that the doctor said, you should move to Arizona. Okay, so there we go. And you would get, the Christmas card from them or the whatever, the Hanukkah greeting card. And for the first year, things are great, we love it here, the allergies and asthma are great. And even the second year, maybe, but then after that, you kind of lose touch, right? But the reality is they weren't doing so well because if you have the tendency to be allergic after you've moved somewhere and you've seen something.
So it takes a while to get the triggers.
Yeah, then they start becoming allergic.
Isn't that fascinating?
So with allergy shots, there really is something, so you can take allergy shots at whatever point in your life. Just like you could get braces at any point in your life. But most people go ahead and get their braces when they're kids and the parents are paying for them and like, let's take care of your braces. And then you're usually good. Kind of same with allergy shots. Like most people go ahead and start, or should start when they're in childhood. But like they can be adults and we can still start them. But if you start them when they're young, early elementary school, it's kind of a magical period. where you can kind of halt that immune response. There's something called the atopic march. So back to atopy is the tendency to be allergic. So the way allergic people manifest tends to be eczema when they're babies, and then that kind of develops more into nasal eye symptoms, allergic rhinitis, allergic conjunctivitis, and then that often becomes asthma. And if you go ahead and start their allergy shots for their nasal eye allergy, for whatever they are positive to at that time when you tested them, and go ahead and do their series of shots in elementary school, you can often stop that progression to asthma. And even though they were only being desensitized to whatever, oak and birch pollen and a couple of grasses and maybe dust mites. When they're older and now they've gone to college in Seattle and then they're moving to Arizona for their first job, they're more likely to not become allergic to the stuff there, as opposed to if I started you on allergies, not you, you're not allergic. If I started you
I might be, so that brings
Okay.
me to our next question. I never had allergies that I remember as a kid, but I would say the last 7 to 8 years, maybe more, maybe 10, every year around November, I'm going to call it asthma. I get a cough, a chronic cough, and it's annoying. And I do tend to take some inhalers to suppress it. Usually they have some steroid in it. And so I feel like I've developed asthma as an adult, and it's very seasonal. It's very specific to the winter. So what is that?
It's adult onset asthma that seems to be seasonal. So is it? Could it be that you're more mold allergic?
I don't know.
Perhaps.
I don't know.
Yeah,
How would you approach it?
So you'd come. You would do a lung function, a simple lung function test in the office. We would probably give you, ask you to bring your rescue inhaler, or we'd give you a breathing treatment or something. And so you blow the lung function. We give you a bronchodilator, like albuterol or something.
Would treat a symptom.
Right, and then we wait about 10 minutes, and then you blow again, and we see if your numbers have changed. So there's some objective data of looking to see if your numbers change, but then subjectively also, when you blow, it's a hard thing to do. Most people say it's a hard thing to do, and most people who have asthma will cough after blowing. And so then after they do the albuterol and then they have to blow the second time, it's like, oh, you know what? It was easier to blow. Oh, you know what? I didn't cough afterwards. So then there's some subjective data.
But
also.
Is it an allergy that I'm
And
experiencing?
so then once I know your lung function is stable enough to test you, then I'll go ahead and do some skin testing.
I see. Would you test me to something specific because it's November and not March?
If you are 100% fine the rest of the time, then I would probably do more fall-related things. But not to call you out, but you sound a little congested, and I don't know if it's
the
because
mask.
Okay.
It's the mask.
Okay.
Absolutely.
Okay. And so but a lot of
It's
that.
the mask. I'm telling you.
A lot of that is really like, are you sure you're 100% okay? And then it, like with really digging in, often it comes from the spouse. Yeah, he says he's fine, but he's not. It's just not as bad. And it's like, oh, okay, then we really should do more.
Do you have some stuff to show us over there?
I do.
All right.
So if you were to allergy test, it's not as terrible as everyone thinks it
It
is.
looks awful already.
No. So they're just little pokey plastic prongs, and so
They're caterpillars.
they're caterpillars, right? So basically, they go in this little dip well, and so there'll be something different. There'll be different kinds of tree pollen on them, or weed, or dust mite, or whatever it might be. It goes on someone's back, just like that.
Okay, that doesn't
Right.
seem bad on the back.
And then it sits there for about 20 minutes. There's a positive control with histamine that's supposed to rise up like an itchy mosquito bite, and there's a negative control with saline that should remain negative.
Gotcha.
And then that way it validates the rest of it. And so basically we're looking to see if you get itchy mosquito bite bumps there. And so, really after 20 minutes, like you know the answer there. Depending on the age of the person or the severity of the symptoms. If they were negative, sometimes we'll do a second line of testing on the arm.
Okay.
So that's that. We were gonna, we were back to the COVID stuff a little bit. So even though it's called hay fever, the seasonal allergy, there is no fever. So that is a telltale sign. If you have fever, it's not straight up allergy. It's really more likely COVID. And if there's itching involved, it's probably allergy. It's probably not COVID. People are freaked out about getting a COVID test.
Okay.
I'm going to show you what the swab looks like.
Cool. So you're just doing swab testing right now. You're not getting antibodies. You're not getting blood and doing that, right?
No, and for a variety of reasons. Number one, it's really not commercially available. There's some labs you can do it. There's only like 8 that are approved right now.
So this is just testing whether or not you're
You
carrying the virus.
Yes.
Gotcha.
And on this, there's a question about it too, in terms of if we actually do this in office,
Yes.
And
No,
how.
I don't run I could do
Right.
the swab collection in the office, but I can't run the test in the office.
And
the test, it has to get sent out.
And so then how long would it be for getting results if you were doing this here versus the drive-through type
I
things?
can usually get a result in a couple of days. Okay.
What about a drive-through tester?
I don't know what UAB is saying now. At one point they were saying 8 to 10 days.
Got it. Okay.
But I don't, that was when we were in the throes of it, and I don't really know
Okay.
anymore. So if you want to get tested here, basically you call, and if you're an existing patient, that it's simple, and if you're a new patient, then basically same deal. It's a little longer visit, but we'll do a video visit. We'll go through what your symptoms are and stuff, and it's like, okay, sounds like you need it or you don't. If you do need it, then we tell you to come at the end of the day after I've kind of cleared out everybody else, and I put on some gear, and then we swab you.
You put on some gear, so you put on some clothing protection, I take it.
I do.
And then what about a hat? Do you wear a hat?
Yes, I wear what you have. I have a.
I wear a hat because my hair's a mess, but
Okay,
other
so
than that,
N95s are really hard to find.
Sure.
I mean, Birmingham's not like New York by any means, but to get PPE equipment here is still hard. And basically, my medical supply person hasn't sold me a mask since January, or gowns.
Sure.
So basically, I'm trying to source that from other places. So I wear an N95, or I actually wear one of those more like gas
but
mask
anyway, you
things.
put
Yes.
on PPE.
Yes, and then you can do it in the throat or you can do it in the nose, but the best is nasopharyngeal. And so basically we ask someone to put their head back, and this goes in, and then it kind of goes down a little bit. And it's uncomfortable.
Goes in
So
your
do
nose.
you have
And I wear a face shield.
Okay, that would make sense
Yeah.
because if you did that to me right now, I would gag all over you.
Right, yes.
Yeah, she has a
Sometimes-
helmet and a face
Yeah.
shield and all that.
Okay.
Yes, and so it is uncomfortable without a doubt, and it will bring tears to your eyes, but it's not the end of the world, and
Okay.
we do that. And
How do people find you? What's the best way? I mean, I just put it in my navy, but how do we get you?
so if you do social media stuff, Facebook, Birmingham Allergy and Asthma Specialists. We're on Instagram.
Beham.allergy.asthma, and on Twitter it's beham_allergy.
And then we have a website, birminghamallergy.com.
And Christy, my who helps me run this, should put all that up. Okay, Christy.
Okay.
Any other questions, Emily?
Maybe I think
It's hard to read off the phone. I know.
Right, it's okay. That's good.
We good?
Yeah.
All right.
Okay.
That was fun.
Okay.
So when we go off here, I want to talk to you more about our transitional year, your internship. Yeah. That's great.
Oh wait, actually one last thing.
Okay.
So just a real quick like recap of doing testing on the back, food or like food trial if you need, and then like patch tests and that you can do by blood work also.
Okay,
So like the different methods of allergy testing.
So prick skin testing is for food and environmental stuff. Blood testing, I can do blood testing for that also. Here is the advantages of doing this, is that I can give you an answer before you leave my office and we can go through a plan. If I do a blood test, I'm not going to know the answer for a couple of weeks. Additionally, this is way cheaper than a blood test. And depending on your insurance, this is important. Depending on your insurance, you're only allowed a certain number of tests in a certain period of time. So if you're going to your primary care doctor or urgent care or whatever, and they're like, oh, we think you have allergy, and they go ahead and start doing some blood work for allergy, and they're like, oh, looks like you have allergy, you should go to the allergist now. They've done you no favors because you've already blown a bunch of the wad of what you're allowed to test, but they didn't necessarily do what I would want to do.
Right, that's frustrating for you and the patient.
Right.
And unfortunately, the reality is there may be some financial incentive for the primary care to have started running these tests.
Yeah.
And so that's a problem too, which is not really what we wanted to get into, but I want to point that out, to be honest. I mean, I think that, how doctors get paid needs to be more transparent. All right, well, we're going to leave it there. Thank you,
Okay.
Clara.
All right.
Thanks,
Thanks.
Emily.